I'll stand on the already read out protocol and I'll go straight to my slides. So I will take you briefly through the burden of sickle cell disease, and I'll try to focus it on Uganda, but also try and look at the family aspects and some key aspects that you see that the government of Uganda is actually doing. So our warrior gave a good description of this slide. So the most important thing that we need to remember is that sickle cell disease has a hallmark. It has a hallmark which describes the pain. It is one of those diseases that are inherited. And if you think of the pattern of inheritance, you need both the mother and the father for you to have a child with sickle cell disease. And in many cases, you do have cases where the father, unfortunately, and I see here where so many men, so we as the fathers deny having the gene and blame the whole disease onto the mother. So let's keep that in mind. And the good thing is I'm talking to a lot of converted people, so it's quite easy for me. So when you think of sickle cell disease and the complications, I just got a few pictures there to kind of like stimulate your mind. You have pain, you have organ damage, and surprisingly, our warrior talked about one of the pictures that I picked. And I didn't know you had your gallbladder removed, but that's exactly what happened. That was what was removed. And most likely there were stones in it, there were sludges in it, and it had to come out. We also have the high risk of infections. So you find young children keep getting recurrent lung infections. And the lung infections are as a result of what we call a functional asplenia. Your spleen doesn't do what it's supposed to do. And if you don't do what you're supposed to do, we don't need you. And that is why you don't have a spleen, because it's not active, it's not doing what it has to do, so it's not present. Other very worrying complications that we think about, you can have the lungs infected, you can have the brain infected. Children with sickle cell disease and adults tend to get strokes. Initially, when I was young, before I joined the medical school, I knew if you got a stroke, you are an elderly person with hypertension, with diabetes, etc. But these children with sickle cell disease, as early as 2 years of age, can get a stroke, and that puts them at a very high risk. Uganda, unfortunately, we lead in many things. We also lead in sickle cell disease. And if you see this map of Africa, where you see the heat map, where it's nice and red, Uganda is part of all those countries. And we're amongst the top 5 countries in Africa with sickle cell disease. And I'm sure you can guess number 1, Nigeria. Okay? And then we're somewhere in between. But more importantly, it is as a result of the protection the gene gives to us in Africa. It protects us against severe forms of malaria. So we propagate this gene alongside because it keeps us safe from severe malaria. If you look at this map, it just reminds us that sickle cell disease is in the whole country. And I hope you can see it. There are a few white places, and that's really down southwest, but the whole part of Uganda has sickle cell disease. It has the gene. So it means any of us can actually have the gene. In this study, which was done about 10 years ago, it tried to describe the sickle cell gene pattern in the country. And we learned on average about 13% of Ugandans have the sickle cell gene, and close to 2% of the population have the disease. So if you do an average, 1 out of every 10 people have a gene here. So as you are greeting that we are here for a landmark event, the person next to you may have the sickle cell gene. Now, when you look at some of the other aspects I wanted to describe in terms of the things that affects us, and it has been clearly highlighted that there is poor growth, there is sickness, there are many aspects, both the acute and chronic complications, but more importantly is that the children tend to have a high risk of morbidity and mortality. With regard specifically to the condition, frequent hospital visits. Many times, many parents may not understand why their child is falling sick, but it's mainly as a result of the disease. They use up big proportions of our health systems. Right now, as I speak in Mulago, sickle cell disease is the #1 cause of admission in our emergency unit, and it takes up all the things that I'm trying to describe. With regard to social impact to families, one key thing I want to highlight is the catastrophic expenditure. People with sickle cell disease, for you to keep that child alive to adulthood, you will need to use a lot of resources. We are fortunate that we have centers that can provide care, but you still have to incur big amount of costs. Economic burden, school, missing work, and I don't know how to say this better. How do we engage our human resource managers not to decline employing people with sickle cell disease? Sometimes some of our warriors come to me and ask, "Doctor, please write a report saying I don't have sickle cell disease, because if I do, I will not get that job." So we have to have some key policies. And these days we use words like inclusion. We have to be inclusive. We have to remember that people with sickle cell disease are part and parcel of our community. Okay. Impact on health systems, recurrent admissions, blood transfusion, and that is one key aspect that we really suffer. We used to worry about mothers giving birth. We used to worry about children with malaria. Now we have to worry about sickle cell disease. They have a high impact on the amount of blood that is consumed. So they have to fight together. And then recently, road traffic accidents, border accidents. So you imagine a child who has sickle cell disease competing with a mother who is giving birth, competing with a child who has severe malaria. And then, of course, you have your road traffic accident. They consume high amounts of blood. Services within Uganda, I would say over the last 10 years, we have had a tremendous increase in the number of services. Mulago has had a clinic since the 1960s, but as I speak now, almost every regional referral hospital, district or general hospitals, and more importantly, even health center FOS are able to provide services with sickle cell disease. Alongside with that, you will see that the newborn screening is something that is very important, because the earlier you detect these children, the better they have better outcomes. This is a landmark event that I had to display. Last week in Kampala, Uganda, we launched the Continental Plan for the management of sickle cell disease in Africa. And we were blessed to have our Minister of Health, our Permanent Secretary, African CDC, and up to 43 countries in Uganda signing up to ensure that we have this plan. And in this plan, one key thing are some pillars. And in those pillars, one was production of hydroxyurea at a local level. Many people were thinking we have to tick those boxes, and I was smiling because I got an email from someone called Natasha, I don't know if she's here, saying that we're going to launch hydroxyurea next week. So I was saying, Uganda, we have ticked off hydroxyurea production. Secondly, in those 8 pillars, there was also testing. Many months ago, also together, and it's quite surprising, with the permanent secretary. She hasn't seen this slide, so she didn't know I was putting her picture up. But she was there. She was present as we launched the mandatory testing. And this is also one of the pillars the Continental Plan has. So already Uganda has 2 out of 8 ticked. Evidence-based interventions. You have things like early diagnosis. You have pneumococcal vaccination. Pneumococcal vaccination was introduced in 2012 in Uganda into the routine EPI program. So we have had this vaccine available, and it's one of the pillars. So I would like to thank the government of Uganda. Some of the things we do, we don't know the impact we're going to have in the future, but it was done so many years ago, and it enables us to take care of these children. And I must state that this vaccine is free for all children with sickle cell disease when they go for booster testing. Cell disease, and more importantly, encourage us to test. If I had a way in planning this program, would have a testing kit session just there, and everyone, before you go for your refreshment, will take off one drop of blood and give you your answer there and then. That's how much technology has improved. In the past, we would test you until you come back after so many weeks to get your results. But within 5 minutes, we can actually know your sickle cell status. Some of the challenges, as I mentioned earlier, availability of blood, availability of resources. Children slowly have grown into adults. And as a result of this, we have a problem with transition. I'm a pediatrician, and she mentioned I'm a hematologist-oncologist, but more importantly, I see children who are sick. In our clinic, those 50-year-olds, those 60-year-olds are still coming to my pediatric clinic. So I'm playing with a 50-year-old, I'm playing with a 60-year-old, and they're wondering what's wrong with this doctor. More importantly, we have the women in their reproductive age. They're getting pregnant. And I'm also seeing a sickle cell lady who is pregnant in my pediatric clinic. So we have a problem with transition, and we have to increase the awareness amongst all the physicians so that they can take up this care. But it's also a pleasure for me to see people grow. I felt quite sad, and I was together with Dr. Chitaka asking, who are those doctors who made those statements? It sounded so hurtful to us. We know that there are challenges when it comes to growth, but we know that we have people who come with sickle cell and grow throughout their lifespan. What are the opportunities we have? And I just want to highlight one thing here. We have been able to develop a national guideline for the management and prevention of sickle cell disease, and it has a 5-year plan. And within this plan, it looks at provision of evidence-based medicines such as hydroxyurea, and it's something that is already within the sickle cell bill that we're looking at. And more importantly, it is one of the policy documents that would allow us to generate resources for us to buy these drugs and ensure that the drugs are available with all people who need the drug. Partnerships, and this is a very good example of a partnership. Public-private partnership for health. The government cannot do everything. Even me as a doctor working in Mulago can't do everything. So we have to work together with partners. Developing the hydroxyurea plant is one of those key partnerships that we can harness. It's something that I need to emphasize. And alongside with that, having advocacy groups. I was looking at your box and I was worried about one thing. It has something called cytotoxic medication. Now, as a Ministry of Health, we have to unpackage that. Someone asks you, what is cytotoxic? You're saying it's going to kill your cells. I understand that must be an NDA regulation, but I'm happy that they used words, because in other countries, there is a skull and bones put on the drug showing danger. So you can't imagine telling someone that this is danger that you're going to swallow. So the partnerships will help us improve the outcomes. As I come to the end of my talk, I just want to highlight one key thing. Every child born with sickle cell disease deserves a chance to survive and thrive. And she is an example of someone who has survived and is thriving. And I'll kindly request us to clap again for her. Thank you all for listening.